Okay, so that you will be able to identify the abnormality of this condition. So pay particular attention to the size of the alveolar space as shown. Okay? That is the regular size of the alveoli. That is the regular size of the alveoli. Now, compare the size of that alveolus to the size of these two alveoli. Okay, so these two alveoli are markedly enlarged and they have fused, their spaces have already been fused with each other. So what is the diagnosis for this condition? This is associated with smoking. So there is an evidence that the owner of this lung is a smoker. What is your diagnosis of the pointed abnormality? Anthracosis. Okay. So another evidence of anthracosis. Now the problem with this lung is that there are regularly sized alveoli which are admixed with dilated alveoli. How do you call that condition which is characterized by dilatation of the alveoli because of the digestion of the wall of the alveoli? What? Emphysema. The condition is associated with deficiency of what condition? Of what enzyme? What? Alpha-1 antitrypsin enzyme. Now, why will there be a risk for the development of emphysema in alpha-1 antitrypsin deficiency? Remember, this individual is smoker. What is the association of alpha-1 antitrypsin with smoking? Last sem pa mga itong pathology of the lungs. Now, when cigarette smoke reaches the lungs, okay, so the smoke will not only contain chemicals but also dust particles. Okay, also contain dust particles. Now, because the dust particles are not normal component of the alveoli, they will become phagocytosed by the macrophages. They will be phagocytosed by the macrophages. Unfortunately, some macrophages, before closing their phagosome, will already release their lytic enzymes. So particularly elastase. And you still remember elastase. Okay? When the wall of the alveoli become exposed to elastase, the wall of the alveoli will become digested. That is why we are now able to see dilated alveoli instead of that normal size of an alveolus. So these alveoli pointed are already markedly dilated because some portions of their wall were already digested by the elastases produced by or released by the macrophages. What is the role of alpha-1 antitrypsin? It is an enzyme produced by the liver, released to the blood. The function of alpha-1 antitrypsin is to neutralize elastase. That is why in deficiency of elastase, there will be no neutralization of, in a condition with deficiency of alpha-1 antitrypsin, there will be no enzyme that will neutralize the effects of elastase. Kaya, nagkakaroon ng digestion sa wall ng mga alveoli. So that is why emphysema does not develop in all smokers. Only those with alpha-1 antitrypsin deficiency. However, this is still not the good news because kung maka-escape man sa emphysema, mayroon pa rin chronic bronchitis, mayroon pa rin lung CA. What is the diagnosis for 177, please? Okay, asbestosis. Now, at that magnification, the tissues of the lungs are obviously inflamed. Okay? So the tissues of the lungs are markedly inflamed, and then inflammation is more dominant in the alveolar spaces or in the interstitium. In the interstitium. That is why asbestosis is classified as an interstitial type of lung disease. So you will be able to diagnose easily asbestosis when you shift to high power magnification. Okay? So on low power magnification, you will be able to identify inflammation and scarring in the interstitial tissues. When you shift to high power magnification, you will be able to see the asbestos bodies. Okay, para silang dumbbell in appearance. Okay, so those are the asbestos bodies. So unfortunately, there is no enzyme in the macrophages which is capable of digesting asbestos. That is why they will stay as foreign bodies in the tissues of the lungs. So asbestosis is characterized by the presence of asbestos bodies which are surrounded by macrophages attempting to phagocytose them, and then inflammation and fibrosis in the interstitium. What type of airway is shown? That one. What type of airway is that? To give you an idea of the name of the previously shown airway, this one contains what type of cartilage? Hyaline cartilage. Now, so you are able to see a plate of hyaline cartilage in the wall of this airway. So how do you classify that airway? A bronchus. How about this airway? Bronchiole. Now, what is the purpose of the hyaline cartilage in the bronchus? Okay. Plate of hyaline cartilage, another plate of hyaline cartilage, another plate of hyaline cartilage. To maintain the patency of the bronchi. Now, unfortunately, for this airway, there is no hyaline cartilage that will maintain its patency. Whenever those muscles contract, what will happen to the size of the lumen? Decrease. Okay? So, as you can notice, the wall of that bronchiole is also inflamed. Okay? When you shift to high power magnification, you will be able to see numerous eosinophils in the wall of that bronchiole. Now, that's the microscopic appearance of mucus. So what can you say now about the lumen of that bronchiole? It becomes obstructed by mucus. These glands are exhibiting mucus hypersecretion. Notice the increased number of goblet cells in the glands or in the epithelium, the respiratory epithelium. So you have mucus. Because of the presence of mucus, this patient will have a reflex of coughing, and because of the inflammation in the bronchiolar wall, the wall becomes thickened, so it will contribute to the decrease in the diameter. The swelling of the airway, the swelling of the wall will contribute to the decrease in the diameter of the lumen. And then those muscles will also contract. they will further narrow the airway. That is why, in this condition, you will be able to hear wheezing. So, what is the diagnosis of this condition? Okay. What type of hypersensitivity reaction is involved? Type 1. Itong 136 bronchiectasis. Okay. Okay. Are you able to see, identify the epithelium pointed? Respiratory epithelium. Okay, respiratory epithelium. Now, let us scan the circumference of that airway. Are you able to see any plate of hyaline cartilage? Are you able to see any plate of hyaline cartilage? How about in that airway? Okay. Does it contain a plate of hyaline cartilage? Wala. So that technically, the airway shown should be classified as bronchiole. However, look at the size of the bronchioles. Is that the regular size of a bronchiole? They have become markedly dilated already. And then as you can notice, the wall is dirty because it is infiltrated by not neutrophils but mostly lymphocytes and macrophages. Note the lymphoid follicle formation. And then the wall also exhibits fibrosis. Okay? Mayroon ding fibrosis. So those are the features of bronchiectasis. The airways will become dilated. So they will become chronically inflamed because of continuous destruction and inflammation in the wall. So what is the risk factor for the development of bronchiectasis? Smoking. So there is persistent exposure to toxic chemicals in smoking. That is why there is also persistent inflammation that will develop in the wall of the airways. So inflammation repair, there will come a time that the dead cells will not become replaced anymore with new cells but with identified abnormality pointed. Eventually, the dead cells will become replaced by identified abnormality pointed. Fibrosis. Very good. So that is why there will be permanent dilatation of the airways that will develop in bronchiectasis. So in bronchiectasis, you should be able to see dilated and chronically inflamed airways. Slide number 142, please. 142.
Hyaline membrane disease.
Hyaline membrane disease. Now, hyaline membrane disease develops in premature infants. So the condition is called hyaline membrane disease because you will be able to see that pink hyaline material deposited in the wall of the alveolar spaces. So what will present with similar histology will be ARDS, acute respiratory distress syndrome. So in both hyaline membrane disease and acute respiratory distress syndrome, the interstitium becomes inflamed. So that is why the interstitium will appear thick in both conditions, and then both conditions will be characterized by increased vascular permeability. That is why there will be fluid, there will be leukocytes inside the alveolar spaces already. And with further increase in vascular permeability, so severe degree of inflammation, eventually fibrin, where is fibrin normally located? Where will you be able to see fibrin? In what tissue? Sino mga medtech dito? Saan makikita ang fibrin? It is one of the coagulation factors. That is why it should be normally present in the blood. Now, what happens to the blood vessels in inflammation? There is vasodilatation, which is followed by increased permeability. That is why we will be able to see edema in inflammation with further increased permeability. Eventually, fibrin will be allowed to escape the wall of the blood vessels. That is why yan is a manifestation of severe inflammation already. So, kaya makikita din siya sa ARDS. So, acute respiratory distress syndrome. Because of the presence of these fibrin deposits from the blood, because of increased vascular permeability, what will now happen to the rate of diffusion of gases? Decrease. So, this is the problem. This will be the cause, the mode of exit for individuals with hyaline membrane disease and acute respiratory distress syndrome. So there will be difficulty in the oxygenation of blood because of the presence of the hyaline membrane, which is composed of fibrin, that will block the entry of oxygen from the air to the blood in the capillaries. That is the problem of this lung, of that lung. That is a blood vessel and it is almost completely obstructed by an embolus. Okay? How will you differentiate an embolus from a thrombus? So you will be able to see attachment of the obstructing material in thrombus or in an embolus? Thrombus. Okay, ito, hindi siya naka-attach. However, it has caused marked obstruction or marked decrease in blood flow already. How will you call the alternating lines of red band and light band? Lines of sun. What composes the lighter bands? Fibrin. So, that should be the diagnostic portion for this slide. Now, the stain of this slide is very faint already. However, okay, much of the inflammation will be seen in the interstitium because there are remnants of the alveolar spaces that can still be appreciated. Now, diagnostic for this slide will be those pink-colored materials. So let us zoom in to the pointed . Okay, so they are not normal components of the lungs. That is why we are able to see lymphocytes and macrophages surrounding them. Okay, so what is the diagnosis for slide number 133? What? Okay, coccidioidomycosis. So those are the fungal spores of the spores of coccidioidomycosis. Okay. So in fungal infection, what type of inflammation will develop? Is it acute type of inflammation or chronic type? Specifically, what type of chronic inflammation? Granulomatous. You should be able to identify this in the practical exam. Slide 220, ano diagnosis please? 220.
Pneumocystis.
Okay, pneumocystis carinii. Now, it is very easy to identify and to diagnose this condition because of the characteristic stain that is used. So, the tissues of the lung will appear brown to black to demonstrate those organisms which are now the pneumocystis carinii. So kindly read on the states of this organism that is capable of infecting the lung. So that will be your assignment. So states of pneumocystis carinii. Have you discussed the coccidians in parasitology already? Wala ba? Anyway, you will be able to encounter them again when you study the coccidians in parasitology. What is the predisposing condition for the development of pneumocystis carinii infection? Okay, severe immunocompromised state such as in HIV infection. Okay, what are the structures that you can identify? Yan, anong shape, anong ina-form ng mga cells na na-point? They are forming glands. Very good. They are forming glands. And then let us look at the cells lining the glands. Okay? So that is one gland, and then another gland, and then another gland. They have fused with each other. What can you comment about the appearance of the nuclei of the epithelial cells lining the glands? Are the nuclei uniform in size and shape? How do you call that in neoplasm? Pleomorphism. What happens to the NC ratio of the cells? Increased NC ratio because the nuclei have become markedly enlarged relative to the size of the cytoplasm or the entire cell. So this neoplasm is composed of tumor cells which are forming glands. How do you diagnose this condition? Adenocarcinoma. Adenocarcinoma. Okay, so that is also another irregularly shaped gland with marked stratification of the tumor cells lining the gland. Now, adenocarcinomas most of the time will have firm or hard consistency because of this response of the stroma or the connective tissue. How do you call this fibrous response? Desmoplasia. Very good. Of the stroma in the presence of the tumor cells. So you will be able to see same type of histology in any organ that will develop adenocarcinoma. Because adenocarcinoma is a malignancy composed of glands lined by tumor cells. So you will be able to see this type of morphology in adenocarcinoma of the uterus, adenocarcinoma of the large intestine, or anywhere in the body. Okay, the abnormality in this lung can be seen in the interstitium. What is your diagnosis in the interstitium? Anong nangyari sa inflammation? Mayroong inflammation sa interstitium. Okay? So, okay, there are leukocytic infiltrates already in the interstitium. However, another prominent abnormality will be seen inside the alveolar spaces. Okay? Are the alveolar spaces patent still? Not anymore because of the presence of identify fats. So mostly these fats are already inside the cells pointed. So expectedly the cells pointed should be called, they should be the macrophages. So engulfing these foreign bodies which are composed of lipids. So, are lipids normally present inside the alveolar spaces? No. So, this is lipid aspiration pneumonia. So, you should be able to see lipid droplets within the macrophages with an accompanying inflammation of the interstitium. So, lipid aspiration pneumonia. 135. Tama? Oh. So this is the diagnosis for this slide. What? Diagnosis. Chronic passive congestion. Identify the cells pointed. Okay, they are macrophages which are laden with hemosiderin. What is the most common cause of that condition? Heart failure, congestive heart failure, particularly left-sided or right-sided? Will you be able to see this abnormality in right-sided heart failure? Will you be able to see this abnormality in right-sided heart failure? No. Kasi, remember, heart failure, the heart fails to perform its function. What happens to blood flow? Kakaroon ng backflow. Pag mayroong right-sided heart failure, magbabackflow ba ang blood to the lungs? To what organ?
Liver.
To the liver first, not to the lungs. Okay? So that is why this condition is associated with left-sided heart failure. Thank you, sir. You should be able to diagnose this condition already. That is the characteristic abnormality that is autognomonic for the condition. Ayan pa. Hanap tayo ng characteristic. Ayan pa. That is the diagnosis for this condition. Sarcoidosis. What type of inflammation is involved? Granulomatous. Will you be able to see caseous necrosis in this condition? Ayan. Inflammatory giant cell pa. So, non-caseating granulomatous inflammation. So, what type of hypersensitivity reaction is involved in sarcoidosis? Type 4. So, that is the characteristic appearance of non-caseating granulomatous inflammation. How do you define granulomatous inflammation? Infiltrates of what type of leukocyte? Particularly the epithelioid macrophages or the activated macrophages. Those cells are responsible for activating the macrophages. They should be the CD4 lymphocytes. Very good. Parang lumabas ito sa quiz kanina. The stroma exhibits desmoplasia. And then the tumor cells are grouped into nests, which are specifically called the cell balance pattern. How do you diagnose this neoplasm? It is composed of uniformly sized tumor cells with eosinophilic cytoplasm. Sometimes those cells are capable of secreting hormones. Carcinoid. So just memorize that typical appearance of carcinoid. The tumor cells are arranged in nest or imparting a cell balance pattern of arrangement. Then they are surrounded by that characteristic response of the stroma, which is called desmoplasia. Ayan, dapat na po siya na makita ninyo to diagnose the condition. Okay, we are looking at the histology of a large bronchus. Normally, the bronchi are lined by what type of epithelium? The bronchi are lined by what type of epithelium? Respiratory, which is pseudostratified ciliated columnar. Now, what happens to the epithelium of that bronchus? Is it still respiratory type? What type of epithelium can you identify? Stratified squamous epithelium. How do you call that change? From one type of epithelium to another type of epithelium? Metaplasia. Now, the owner of this lung must be a smoker because of chronic injury caused by the chemicals in the smoke. the epithelial tissues of the airway have been transformed via metaplasia into a stratified squamous type of epithelium. That is the most tough type of epithelium present in our body. That is why it is present as the covering of our body. So, mas mayroon siyang resistance against harmful chemicals. So, that is why, from respiratory epithelium, nagkaroon ng metaplasia, the epithelium becomes transformed into stratified squamous epithelium. Now, can you still remember the normal maturation pattern of the squamous cells in the squamous epithelium? Normally, the cells at the basal portions will have larger nuclei. And then as the cells ascend to the superficial portion, nagkakaroon ng decrease in size of the nuclei. How about those nuclei pointed? Okay, that is loss of normal arrangement of the cells already, or loss of polarity, wherein those pointed nuclei should be present at the lower layers normally. However, they are already present at the superficial layers. How do you call that condition? Loss of polarity. Dysplasia, which is a fertile soil for the development of cancer. Dysplasia. So, hindi pa nag-stop ng smoking ang owner ng lung na ito. So, eventually, from dysplasia, a malignancy which is limited to the epithelium has developed as evidence in that portion. So, full thickness dysplasia. So this is already a malignancy limited to the epithelium because the basement membrane is still intact. What is the diagnosis for that condition if this is malignant already? Squamous cell carcinoma in situ. Squamous cell carcinoma in situ. Unfortunately, nagkaroon na siya ng in situ, sige pa rin smoke, kaya eventually, instead of just being limited by the basement membrane, the cancer cells have infiltrated already the underlying connective tissues. So what is now the diagnosis for that portion? Okay, so it's invasive squamous cell carcinoma. So to technically differentiate this malignancy from the in situ, which is still limited to limited by the basement membrane. Here, we see malignant squamous cells already in the deep tissues of the airway. How do you call that characteristic response of the stroma? Desmoplasia. What is the road for metastasis for this neoplasm, being a carcinoma? The initial road. Direct seeding, lymphatics, blood vessels. The stain is very faint already. What is the diagnosis for 219, please?
ARDS. ARDS.
Okay, ARDS. Now, ARDS is not a specific disease entity as what you have studied in the lecture. So, hindi siya specific disease entity, but an outcome of severe lung disease. So what are the possible causes for the development of ARDS? And there is a table in Robbins listing all the possible causes of ARDS. Actually, before we die, especially pag mayroong problema sa lungs, Yan ang mangyayari sa lungs. Magde-develop ng ARDS, especially in sepsis. So, magkakaroon, the problem is with increased vascular permeability, allowing the escape of fibrin from the blood to become deposited in the wall of the alveoli. So that is why, as we can notice, there is marked thickening of the wall of the alveoli in that lung because of the deposition of fibrin, which should be normally present in the blood. So the abnormality that you should be able to see in this slide to come up with the ARDS diagnosis is the marked thickening of the alveolar wall. So, pwede nyo itong i-diagnose as anthracosis or silicosis. Pero, silica is very hard to identify. Mas technically correct if you diagnose this as anthracosis. Kuha na ni ginhawa ni kuha na ni. Okay, that is our last slide for this discussion. Do you have any question? Would you like to have a practical quiz? Actually,